Right, so good evening, everyone. Thank you for joining this online webinar on behalf of DOGANE, which is Dow Graduates Association of Northern Europe. It's a registered charity in UK, and we are basically alumni of one of the colleges from Pakistan with a lot of doctors working in this country. So just a brief introduction for those who are not aware of what DOGANE stands for. I will quickly hand over to our chairman, Dr. Shahid Gill, who will take us through the proceedings, and we have an excellent panel of four speakers. Just one thing to point out, we would like to thank our sponsors, but obviously Dr. Gill will tell us more details about them. If at any stage during this presentation, there is a technical glitch and we get disconnected, because it can happen, please reconnect using the same link 2 minutes later and we'll be back on. So without any further delay, I'm Saqib Ghani, by the way, president of DOGANE, and I'm going to hand over to Shahid Gill. Dr. Gill, over to you.
Thank you, Saqib, and a very warm welcome to all people attending our seminar, our webinar. And a real pleasure, we have an excellent lineup of speakers this evening on a topic very relevant to GPs and primary care. Just a brief message about from our sponsors this evening. As you saw the posters, one is ENT Masterclass, which is an international training platform providing free training in 4 continents, including Pakistan, and was founded by a graduate from Dow Medical in 2005, and has provided huge resources over the last 15 years towards the training of surgical trainees. DP Medical is a United Kingdom-based international medical equipment supplier for primary and secondary care, mainly supplying high-quality diagnostic equipment such as microscopes and flexible endoscopes. So our huge thanks to both those organizations for helping us sponsor this evening. And we'll now get on with our webinar. About 6 weeks ago, my colleagues asked me as a GP, and having been a GP now for 30 years, I think I've seen a generation of change. And 30 years ago, cancer diagnosis was certainly not as good as it is today in primary care. And I felt that over the last few months, especially with the effect of the pandemic, with dozens of people simply not attending and the way surgeries were, just as hospitals and trusts are struggling with their restoration and recovery, I think it would be very useful for GPs to again go over things which they could manage safely in primary care and things which would need to be sent to our colleagues in hospital urgently. And we've got a host of speakers covering different cancer referral pathways. And I'm going to start with Dr. Khurum Khan. Dr. Khan is a consultant medical oncologist at the University College Hospital in London and an associate professor. He's actually going to give us a look into the future of how GPs, primary care, and secondary care could collaborate in the future to assist rapid diagnosis. So, Dr. Khan, the floor is yours.
Thank you very much. Assalamu alaikum to everyone. And firstly, I would like to profoundly thank the sponsors, Dr. Gill, and all the organizers for this extremely kind invite. It's an absolute pleasure to be delivering this talk. So I'll be, sorry, first, can I just check, can you see my slides all right?
Yes.
Yeah, okay. So the next few minutes I'll be spending actually in talking about the evolving landscape of lower GI cancers and their management and the role of genetic testing. So it's a relatively new idea, but it's becoming more and more prevalent in our clinical practice. And I'm pretty certain that in years to come by, not in too distant future actually, these things will become part and parcel of primary care management as well. So the first thing I would like to state is, so I work for University College London, and I have a strong interest in research. And I think it's important to recognize that, particularly in cancer care pathways, one of the recommendations from NICE is to be able to at least offer 20% of the patient's clinical trials. So it is part of the good clinical practice. So really, research is not just innovation, but it's also part of our clinical practice. And a good clinical practice, we all would probably agree, that's where the evidence is derived as a combination of clinic and research, and it's a balancing requirement between the two services. So in terms of cancer, we all know actually that one of the critically important things is recognition of symptoms, early diagnosis. In UK particularly, this is an area of interest. So if you look at the data from CR UK, the Cancer Research UK, or BRC, all the cancer foundations, one common theme is that unfortunately UK is underperforming compared to the rest of the developed countries when it comes to early diagnosis and management. The point I would like to highlight here is that it's never too late, because there is a general perception about cancer that if you present at stage 4 disease or very late, then really, yes, I agree, it's a balance between the quality of life and what you can achieve with different anti-cancer treatments, but things have changed a lot. So really, even if the patients are not diagnosed early enough, if they present in the primary care at a stage where you feel that they cannot be cured, there are still treatment options which may have a significant impact on their lives. So this is just to highlight some of the data actually. So bowel cancer is where my interest is. I treat all GI cancers, but bowel cancer, my research was in bowel cancer, and I've run clinical trials in that as well. Part of the reason is it's the third commonest cancer in the world, still associated with quite high morbidity and mortality. So you'll see in the next few slides, I've focused on the general principles of treating GI cancers. So again, I think quite pertinent to the patients who present to the GP surgeries. There is generally, you'll see a lot of overlap in the symptoms. And obviously with experience and with more maturity, people are able to distinguish between some of the symptoms. However, there can be an overlap, which is where I don't envy the role of our primary care physicians colleagues, because they see patients with variety of symptoms, and some of them can be sinister, others may just be routine symptoms. So how do we differentiate between that? And that's where I'll allude upon later on in my talk actually, that as to how these things are likely to improve in future with the help of research that us and many other groups are doing. So yeah, I mean, I would not read out everything in this slide, but I think the key things to say in colorectal cancer is blood, PR bleeding, change in bowel habits, and iron deficiency anemia should always be alarming signs actually. And I've come across in my practice many a times patients who've been going back and forth to their practices sometimes with these symptoms. And I think part of the thing that I would emphasize here is that gone are the days when we used to associate cancers with certain age groups. So what I see commonly in my practice is that actually a lot of patients who are young in their 30s, 40s, they present to the GPs, and for obvious reasons, the threshold for considering cancer in that situation is low. So I think is high rather. So I think the important thing to keep in mind is that these days actually a lot of patients with young age actually can still present with cancer. And to be honest, it looks even bad and actually medico-legally unsafe if those patients who are in their 30s or 40s have been to the primary care physicians multiple times and then they're diagnosed with cancer subsequently. So what are the investigations? So I think the important thing from the primary care pathway point of view is actually to initiate this 2-week referral pathway where appropriate. And the investigations which are required are still, despite all the advancements, still colonoscopy, biopsy. I think biopsy for us is the key in terms of establishing the diagnosis because at the end of the day, as an oncologist, we are unable to offer any anti-cancer therapies until we have a definitive diagnosis. And there are many reasons for being adamant about the diagnosis. Sometimes actually it's to the extent where it becomes frustrating, for example, with the pancreatic cancers, where sometimes you have to attempt the EUS or biopsies multiple times, they are unsuccessful. But I think it is critically important to recognize the need for biopsy and that initiation of the pathway which leads to the quickest facility in terms of biopsies. So I think from the primary care pathway point of view, if you look at all these investigations, so although the focus of my talk is colorectal cancer, but I would just emphasize the EUS facilities, for example, for pancreatic cancer are not available in all the hospitals. The PET scans are not available in all the hospitals. So if you're coming across a situation where you have to decide where the patient is best served, then it might well be a university hospital where some of those investigations are more easily available. However, obviously, I understand there are pathways which need to be followed appropriately. So this slide just highlights that a lot of patients with GI cancers present late, and that's what I was saying earlier. 50% in colon cancer, 70% esophagogastric, and then 80% pancreatic cancer patients present with metastatic disease. Now, important thing is that there's a group of patients with colorectal cancer with oligometastatic disease, so low volume disease that can still be cured. So now I would be talking about what we've done for these patients over the years. So just to highlight, up until a decade ago, the survival for these patients with metastatic colorectal cancer was 6 months or below. Now we are at this stage with various testing, the molecular testing, that we can reach up to 35 months for these patients. I mean, these are averages. I've seen patients who have been alive for 5 years or beyond with bowel cancer. These are the tests that we do routinely at the moment. So this is what we have in clinical practice. Every single patient with diagnosis of bowel cancer gets KRAS, NRAS, BRAF, and MSI. 5 tests which are standard of care, they get them done. I think the point of highlighting that is that we have made some advancements actually in terms of genetic testing. So these are the somatic mutations which patients are likely to acquire because of various genetic aberrations over a period of time due to environmental factors, due to genetic predisposition or other factors. But these are somatic mutations that we should test for in almost 100% of the cases, unless there is an issue with availability of tissue. And then there's a role of immunotherapy. So just to briefly say actually that immunotherapy has really dramatically changed the outcomes of cancer patients. I mean, when I was looking for my PhD project, immunotherapy PhDs were available. And actually, I was advised not to do an immunotherapy PhD because it doesn't work for anyone. Unfortunately, it transpired that it does not only work, but actually in some cancers where the prognosis used to be something like 6 months to 9 months, now their 5-year survivals are approaching 50%. Concept in layman's language is to activate your own immune cells to fight against the cancer cells. So all these latest therapies are taking us towards this concept of personalized medicine. So personalized medicine in general terms is the ability to offer that treatment to the patients which is going to offer them maximum benefit and minimal side effects. This is how technically it is defined. I think from my point of view, when I see my patients, and I'm sure many of my primary care physician colleagues would agree, it's not just about that. Actually, it's about a full package, a social and clinical package, whereby you select your patients based on their preferences, based on their circumstances, based on their performance status, and based on the clinical aspirations available in that area. So what we've done, my research was focused on looking at the modern ways of doing the biopsies. And this, I think, is the future. In fact, it is prevalent in a lot of research institutes in UK and the rest of the world already. So what is the traditional way of doing a biopsy? You take is essentially looking at, liquid biopsy is looking at the circulating tumor cells. So essentially when you do a plasma sample, simple blood test, 3 to 5 ml sample, you can look at any genetic mutations. You can look at, selected mutations like 5, 7, 10, or you can look at a bigger panel of 50, 100 mutations. You can even do a whole exome or genome sequencing, looking at hundreds and thousands of mutations actually in that small plasma sample. So what are the advantages? So I'll quickly go through them. Obviously, it goes without saying, it's less invasive procedure. Compliance would be at the moment lowish, but will be high. It is more cost effective. It gives us results quickly. There is repeated access possible. At the moment, obviously, it is still not in a validated clinical setting, but it is becoming actually more and more evident that this will be the case in near future. So how did they enter the clinical practice? So I'll take you through some of the research that I've done actually. This was the paper that we published in Cancer Discovery in 2018. And what we did was this trial whereby we collected the tissue sample pre-treatment, then we collected the samples during the treatment before starting. So this is actually archival tissue samples. So these patients may have had sampling 2 years before before this treatment, which was offered on this trial. I'll not dwell too much on the trial itself, but it's mainly to demonstrate that we took tissue samples, sequential tissue samples on multiple occasions. We had the radiological staging on those occasions, and we took plasma samples every 4 weeks and tried to link these samples to each other. And what we found was amazing findings, actually. So if you look at this diagram, it appears complex, but actually it's very interesting. So this is the diagram of the liver. You can see in one of the segments, segment 2 and 2B, we did the biopsy of that segment. Then we did the biopsy of the segment 4. So different segments, same metastatic disease. And then we had the tissue available from the primary. And if you look on the right side of the panel, you'll see actually that those mutations which were available in one segment, like this NRAS mutation, was not available on the other, was not evident on the other segment of the same liver. So how amazing and fascinating this whole thing is. Unfortunately, not for the patients, but from scientific point of view, you can see this heterogeneity, that one tumor cell in the same organ behaves in a different way compared to the other tumor cell within the same organ. And this is where we are dealing with the complexity. So what is the disadvantage of the solid biopsy? So you're actually focusing in one area where you're taking the tissue, despite subjecting patients to multiple potential complications. You're taking that sample, but you're not actually fully aware if you're actually hitting the right area or not, because the other area might be behaving in a different way. So what we found on this liquid biopsy testing was that we were able to negatively select patients who were never going to benefit from this treatment, and positively select patients. So you'll see where I say positive selection, what it means is that these mutations were identified and there are treatments which could target these mutations. So what we are, in terms of futuristic impact of this, is that we were looking at how we can forecast progression or resistance. So it's fascinating. So I went to one of my colleagues who's actually a mathematician, and he highlighted that there is this fascinating concept that since I came to UK, I'm sure you've all experienced the same. When we were in Pakistan, somebody would say that tomorrow there will be rain. You'd laugh about it. But here, you can be 90% or more certain that if there's a prediction about rain, that is going to happen. So this chap said to me that why can't we do it in medicine? Why can't we say that this patient is likely to progress? And this is what we came up with. So despite the scans were showing that the disease was stable. But if you look at these graphs, they appear complex, but again, very interesting. So you see where it says molecular progression, we were able to find this progression in advance of time, meaning that the scans showed progression 2 months later, but we knew that the treatment was not going to work. So we came up with these strategies that, when you're on treatment A, you stop this treatment. When you know that this patient is going to progress, give them a different treatment or a holiday from the treatment, which reduces the selective pressure on the cancer cells. And then you go down to the second or third line treatment and maybe re-challenge with the same treatment. I think these formulas, I'll skip those, but I think the point I'm trying to make is that, like this weather prediction, we are being futuristic, moving in the direction where we'll be able to, with these blood samples, predict whether the patients are likely to progress or not. Likewise, I performed this study as well, which was set up and was published in Gut. What we showed was that when there was a drop in the circulating tumor DNA, there was a proportionate response to the treatment, identical response. So if there was a drop in the ctDNA, the patients were benefiting. If there was not, the patients were not benefiting. Why I am highlighting all this? There are a few reasons. So I think the first section was to say what the liquid biopsies are. From the primary care point of view, I would envisage that in near future, the liquid biopsies would become available. hopefully first in the clinics and then in the primary care facilities as well, whereby patients who had early cancer diagnosis would be possibly followed up in the GP surgeries with these blood tests. If the blood tests ring any alarm bells, then they'll be referred back to the secondary care pathways. The second point I want to make for all the students from Dow and with all the humble, all the colleagues and seniors and juniors, I think we can do a lot of collaboration working together. And these are some of the examples. Since I came here, actually, I've been doing a lot of service evaluation projects. And whilst working in primary and secondary care, there's a lot of room for taking research forward, both in the UK and in Pakistan. I think if we work together, we can, improve the teaching and training experience. I think it's all about sharing the opportunities between all disciplines. So it does not matter whether, and we were oncologists or primary care physicians or hematologists or any other disciplines. I think there's a link these days, actually, there's a link between all specialties. So for example, Saqib here is a cardiologist. We work very closely with the cardiologists because a lot of chemo drugs, the Herceptin, the targeted drugs, they can cause cardiotoxicities. So the key for me is a successful bond between the GPs and oncologists and other disciplines. And I think it's about collaboration and respect. So I believe that every single person who's involved in a team brings their special, special aspects to the greater working of the team. So it's a matter of respecting those. So building relationships, working on clinical trials, improving research. And research doesn't mean just being involved in trials, but I think other aspects as well, and getting involved with the patients. So that's all I had to say. I think it's about teamwork, commitment, and finally equity of care. I think the key is that I would like everyone to be treated in a way as I would like myself or my family members to be treated. And all of us can be good team players and contribute to the development of society in Pakistan and also the medical society in particular. And we can work together, hopefully, inshallah. Thank you very much for this opportunity. I'm really, really grateful.
Okay, thank you, Khurum. Really fascinating look into the future. And as you say, hopefully not too distant a future. Your graphs around, the survival in metastatic disease are excellent. And I think what GPs would be looking for would be, again, would these liquid biopsies eventually help us with, even, the graphs you were showing of the molecular change, which you can't see obviously in a scan.
Yes.
Or you can't see that in a lump on a patient yet. So, are these things in the distant future, or will they be, coming around soon? Yeah.
So I think inshallah in very near future, because there are two aspects. So one is the metastatic disease management, which is mainly at the moment confined to bigger research centers. But for early stage disease, the key is that when they go on the surveillance pathways, the problem is that they should not have mutations in their plasma, essentially. That's a very simple concept. If they have mutation, that is suggestive of some form of malignancy in them. So at the moment, there are two areas where there's a lot of work going on. One is the surveillance pathways, and the other are the diagnostic pathways. So the ctDNA actually is in a lot of.
Okay.
Particularly in London, I'm aware, in North Central London Cancer Alliance, they're already looking at diagnostic pathways. So I think in next 2 to 5 years, I wouldn't be surprised if it is actually becoming part of the clinical practice.
Thanks very much. I can't see any questions in the chat. I would request all colleagues and attendees to please put their questions in the chat.
May I ask one, if you allow?
Yes, please, Saqib.
Dr. Khurum, excellent talk. One question, I'm not a GP, but let's say if I'm sitting in a GP practice, Shahid Gill probably can add to this. How what could they do to help recruit more patients to these trials from primary care? Because my understanding is most of them are recruited from secondary care. Is there something GPs can do to help you recruit more patients or other trialists around the
Thank you very
country?
much. That's a great question. Actually, so there are two aspects. So one is obviously there are some trials where the GPs are indeed participating. So for example, any pathways where let's say the colorectal screening pathway was activated through the GP programs essentially because the patients were sending their samples there, and that's how it all became part of the clinical practice. So actually, in the early diagnosis, the research active GP surgeries would be participating in these trials. That's number one. Number two is I think there is a broader way of contributing to research. So for example, I sat on research ethics committee in London, and actually it was always led by the GPs. So again, there's a huge contribution from the primary care physicians because again they are also looking at within the CCG, what sort of money distribution, what sort of trial distribution is possible in terms of allocating the resources. But thirdly, I think, which is probably the most important aspect in the primary care, as well as us, educating our colleagues and people, particularly those who are based in, let's say, Birmingham or in areas where there are lots of Asian community. I think is to educate people about the role of clinical trials, because I'm sure all of us have experienced that COVID is one of the examples where even the data showed that the vaccination uptake was very low in Asian prevalent areas, particularly Pakistani communities. So I think it's a matter of educating and contributing wherever we all can.
I see a question from Tariq Sami. Again, Khurum, I think maybe it's been partly answered. The question is, why do you think that the research, the translational research, has not found its place in GP practices and mainstream medicine?
I think it's multifactorial. It's, to be honest, it's a very good question. It's not just limited to be honest, primary care, but in secondary care as well. And if I be honest about it, the simple answer is, so I did my CCT in 2013, and then I spent 5 years, roughly 5 years in research. During that time, I worked at at a basic salary of a senior registrar. So I think there's a lot of, so that's one area which is an honest answer. There's a lot of involving in research means a lot of sacrifice for a long time period. I'm not saying people are not prepared to do that, but it's a lot of price to pay when people, and in the science world, the problem is it's all, then linked to your grants and then publications and everything. So it's a very difficult, unfortunately, despite even in Western countries, despite saying that they want to promote research, there are lots of blocks there. But the second area obviously is that the balance between the clinic and the research. So of course in GP practices, I mean, I would say I don't envy this actually. I mean, you do far better clinical job than we do in the clinics. I see patients who've already got diagnosis of cancer. You're seeing patients who are coming with hundreds of symptoms, and probably 95, 99% have no cancer. So obviously, when you're involved in such heavy clinical practices, it takes a lot of motivation to be still part of clinical trials. But there are people who are still contributing.
Okay, well, thank you very much, Khurum. Thanks for your time. Really excellent talk, and sort of look into the future as to what we can look forward to. Let me just make sure if there's anything else before you go. Saqib Irfan is just asking, are there any plans to, because of the bowel cancer frequency being more detected in younger people, that the screening program, the age limit can be reduced to 60 rather than 60?
Indeed, it's not just 60 actually. So there is a proposal in NCL in London actually, central London. So a lot of GP practices are already offering it at the age of 50. So it is inevitable. I think this has to happen actually in near future, where the age goes to even 45 or 50, around that number, because it's a diagnostic test which is available and it makes a huge difference. As you'll be hearing later on about PSA, the problem is there is still controversial evidence as to whether the PSA screening makes a difference or not. I don't want to steal the thunder there, but I think the main point is that this is a proven strategy which improves the outcomes in cancer patients. So certainly, I'm sure it is on the cards.
By the way, we'll
Okay,
move to the second speaker now. Thank you.
yeah, thank you. Thank you so much, Khurum.
Thank you very much.
We will move on to our next speaker. Again, I have the pleasure of asking Syed Iftikhar Yusuf, who is a consultant surgeon and associate professor at the Royal Derby Hospital. His interest and surgical specialty in upper GI surgery. Mr. Yusuf has been heavily involved in education and also amazing charity work, both UK and across the world, and someone who I have looked up to for years. So I'm really honored to have him at this forum, and I welcome you. I think as a GP, every time I speak to someone who said they have slight difficulty swallowing, I'm not always sure whether to refer them after 3 weeks or 6 weeks. So, you know, perhaps you can talk to us about these simple symptoms and perhaps allay some of our anxieties this evening. Please, the floor is yours, Iftikhar.
Can you hear me, Shahid?
Yes, we can.
Yeah.
Yes.
Good evening, folks. Thank you for inviting me. It's a great pleasure. And having spoken to various forums over the number of years, this is the most important one for me because it belongs to Dow alumni. And thanks for calling me and asking me to give my presentation about esophageal cancer. This subject is dear to my heart. I've spent my entire academic life looking at
Iftikhar, just do you want to speak up a little bit? We are hearing very faint.
Yeah, if you can put up your speaker volume a bit. Can you pick up your speaker volume?
Hello?
Perfect.
That's better. Thanks.
Okay. What I said is that I've spent all my life working with esophageal cancer, looking into the issue of its etiology, its progression, its epidemiology, and its treatment. Okay. So without further ado, I would declare that I have no conflict of interest in my research or in this presentation. Okay. I work at this University Hospital of Derby. I never had intended to work at any teaching hospital. I had joined a district general hospital in 1994. I was never an academic, but ended up being an academic and at a university hospital. That's by default. For people who don't know the anatomy very well, it's a very small, short organ, about 25 centimeters in length. It starts from the cricopharyngeus and ends at the gastroesophageal junction. There are 3 segments of it. I won't go into the detail of those 3 segments. What is important is that this gentleman, as you see, is doing something very unusual. And there's a lot can be said about unusual pathology among Chinese people as regard to esophageal cancer. I'll come back to that. But esophageal cancer is predominantly happening in Caspian Sea area, in north of Pakistan, Afghanistan. There used to be 7 cases per 100,000 per year in Britain, and 135 cases per 100,000 in Linjiang in China. South Africa, Transkei, had similar incidence of about 80 to 90 cases per 100,000 per year. Closest to us is France, right? Brittany. Brittany had the maximum incidence, 20 cases per 100,000. Why did that happen in Brittany? Because their dietary habit are very different. The interregional and urban-rural differences in the incidence is evident because of Calvados. The hot drinks they use. Chili, this is my kitchen top. You can see green chili is used very often in lots of places. And Chinese are second to none in their habit of eating this sort of diet. Why does in Linjiang they've got such a high incidence? Because it is because of fumoniscence, homegrown corn, and that causes esophageal cancer. British population, I look after these people, right? They had 7 cases per 100,000, but in my lifetime that jumped up to 20. This is an old slide from 2002, but it stayed like this, 20 cases per 100,000 per year. Why did that happen? It happened because of reflux, because of our dietary habit. Lots of beer, lots of fish and chips, obesity. Patients developed reflux, and as a consequence of reflux, they would develop this condition where you see that the lower third of the esophagus has been replaced by metaplastic columnar epithelium. And that is 4% of these cases were known to would develop cancer. And that was written up and proposed by this guy, Norman Barrett. And I worked for this chap, Michael Atkinson. Michael unfortunately passed away last month, but he was professor at Nottingham, and I worked with him and learned a lot from him. Norman Barrett wrote in his seminal paper in 1950 in British Journal of Surgery that I submit that most of these cases are in truth examples of congenitally short esophagus, in which a part of the stomach extends upwards into the mediastinum or even into the neck. But he couldn't be more wrong. What he has described here is hiatus hernia. But he had good friends in Leeds, Allison and Johnson. They said, no, Norman, this is esophagus. This is not a stomach pulled up because there is no serosal covering to this tube. And this metaplastic epithelium, that is Barrett's esophagus. Americans don't call it Barrett's. They call it columnar lined esophagus, CLO. But we British still call it Barrett's because we are very loyal people. My contribution, you can see here, I exist in the list of people who have contributed to Barrett's and its epidemiology and development and pathogenesis. Here as well. Now this model, if you look at the esophagogastroplasty model, which was actually published by Atwood in Surgery in 1993, 92. And if you produce reflux, you can get Barrett's. And very novel piece of work was done by Gill, who works in Cork. He was in Dublin at that time. What he did was that he denuded the esophagus in a flag-like manner, different areas. So there is no epithelium here anymore. And he produced gastroplasty. And so these two areas generated columnar epithelium. So there was something inherent in the esophageal body that will produce, due to reflux, will produce redevelopment of epithelium, and that would be metaplastic columnar epithelium. My contribution to this process was describing that when people reflux and the refluxate comes up to the esophagus, because of the poor peristalsis in these patients, the refluxate is not sent back to the esophagus in quick time. So the contact time of the refluxate is far greater than what it should be. And that was very evident from this work, where I used tin colloid liquid and studied the patients for 2 minutes. You can see here that lots of tin colloid material is still, this isotope is residual in the upper esophagus, and some of it has gone into the stomach over a 2-minute period. And if you look at the manometry and look at the isotope study as well and compare it, you can see that those subjects who had dysphagia, although they had no organic occlusion, they had no malignancy, there was no cancer, but they still had dysphagia, which happens in elderly people. The motility becomes bad. So dysphagia present and dysphagia absent, their data is very significant. So those patients who had Barrett's, they had a significantly delayed emptying of the esophagus, severe dysphagia due to dysmotility. Now, this is the most important thing. I'm very proud to say that my contribution to the surgical science and medical science is the description and defining of bile reflux. The whole world treats acid reflux. The PPIs, the H2 receptor blockers, and all those things are designed to counteract acid reflux. But that is not the only problem. We have alkaline reflux as well. We do know that the duodenal-gastric reflux is a common phenomena, and I analyzed the refluxate in these subjects and found that there are 6 different bile acids present in the refluxate. And I also know that in the model where you produce this alkaline and gastric acid reflux, mixed reflux, the incidence of esophageal cancer in the canine model is significantly higher to the one where you produce only alkaline reflux. Esophageal cancer hence has progressed in this community like anything. Why? My philosophy is that two things, guys who are new researchers, if you're listening, take this on board, that whenever we have reflux associated heartburn, if you give PPI, within very short a space of time, the symptoms disappears, gets better. So that cannot be only because of it is suppressing the acid. The presumption is that the acid comes up into the gullet and stop because of the PPI, there's no acid, so pain goes away. Pain is because of inflammation, because of esophagitis. So if the tablet is getting rid of the pain, there has to be an inherent property to work on the nerve endings to get rid of the problem. So if you want to research in this subject. The use of PPI produces this. What happens is that on the face of duodeноgastric reflux, which I've already said, and you're using PPI, you get alkaline gastric environment. And the bile, the lysolecithin and trypsin goes up into the esophagus and causes catalytic effect on nitrosation, which produces malignancy eventually, alongside mucus destruction. Now, at the end of the day, we all know that esophageal cancer is 5th in the list of important cancers in UK. And I've already shown you this diagram. Also, I've shown you the squamous carcinoma. And as Khurum mentioned, 70% of these patients, they come at high stage 4. When they come, there's very little you can do. They are cachectic. They're not going to live for too long. And vast majority of people require palliative care. They require help with their symptom. How can you help them? You can put a tube down the esophagus to unblock the obstruction. This was the very first paper I ever wrote. That was Michael Atkinson's lifetime work, looking at 144 patients with adenocarcinoma and 125 patients with a squamous carcinoma. Endoscopic placement of a stent was his baby. I learned it from him at that stage and wrote it up. Unfortunately, within 6 months or so, majority people were on the autopsy table. You can see one of the tube here in the esophagus. And these cancers don't have very good prognosis, no matter what you do. I'm very proud of this photograph. There's a lad here working with me in front of me. He was my registrar, and he's now professor of surgery at Queen's Medical Center. By looking at him, you will know that he is Dilip Lobo. Very dexterous, very talented, very intelligent, very bright guy. But even people like him, now he's doing liver surgery and all that, pancreatic. Improvement in esophageal surgery didn't come about very readily. We do all sorts of esophageal resection, total, Ivan Lewis, left thoracotomy, laparoscopic, hybrid, name it. But patient ends up in here. So what can we do to actually improve the situation for these patients? One most important thing happened in my lifetime was that this guy, Prof. Richards, he was an oncologist working at St. Thomas's. He had a call from a colleague of his who was asking him about a breast cancer patient, because the Prof. Richards' interest was breast cancer. Said, look, what can I do about this patient? So he asked certain questions and he didn't get proper answer. So he realized that there is, in vast majority of centers, he did the initial trial and found out that there is no coherent delivery of care for cancer. He set up the National Cancer Directory, and he became a director of the Institute, National Cancer Action Team, and developed 2-week system, an investigation and commencement of treatment within 60 days. That is still happening, and he managed to reduce the centers. Not every hospital now can do esophageal cancer surgery. You have to have, each surgeon has to do at least 15 a year, therefore, and you have to have 4 surgeons in a unit. So you have to do at least 60 cancers per year. Compare that with the statement by Hugo Matthews, the great surgeon from Queen Elizabeth Hospital in Birmingham. He said that anybody who does 5 cancer per year is an esophageal cancer surgeon. That is about 30 years ago. And the world has moved on in that time. So now every patient, because of Prof. Richards' effort of MDT, the need of MDT, I won't go into the detail of this. The characteristic, I won't go into the detail of this. However, NHS Cancer Plan and all that, it happened because of Prof. Richard. Now, overall mortality, you know that surgical mortality for these cases is very high. NICE accepts 10%. Good centers have got 3-4% mortality. That is my personal mortality on the screen. In my department, we have 1.5% mortality overall, and consistently like that for the last 10-15 years. This is the published data and national published data. You can see us down there. Okay. Why does that happen? Because we have progressed. We don't let people bleed too much. We were the first ones to use harmonica scalpel in this kind of surgery. Following this, in my hospital, Max Fax took it up. Keith Jones has started using it and has published on the subject. We do enhanced recovery program like Don Low in Seattle. And next day, this is a patient who got up next day and with the help of physiotherapists is made to walk. Having done all that, you should know that survival is very poor. T1 disease do well, long-term 60% survival, 5 years or more. But in T3 diseases are really down there. Nodal involvement makes it worse. No node involvement is better than any N1 or N2 disease. And this is a slide, is a borrowed slide. Actually, if Naseem Varaj is in the audience, he would know that this is his slide. I borrowed it from him. The outcome for these patients is really, really bad. This is a very important paper, and a lot of discussion has happened and would happen, and people will come up, and because every cancer, bowel cancer, is talked about that vascular invasion is poor. But in esophageal cancer, in our unit, we haven't found that the vascular invasion is important. We haven't found that preoperative lymph elevated neutrophil ratio with the lymphocyte. It doesn't give you predictive value, survival from value as colorectal cancers do. And finally, one subject which is very close to my heart is why women do better than if they have esophageal cancer. Why we men suffer. Look at the survival. Even if they get it, they do better than the men will do. Therefore, two things. Khuram addressed early diagnosis. If we do early diagnosis, that is better. If we do have tools which could assess the proliferation and the cancerogenicity of any disease, that will be better. We have worked on those things. However, all these, if you go back to the Ki67 proliferation, if you work on the DNA image cytometry, none of them actually made any positive contribution to the prediction and outcome of malignancy in Barrett's esophagus. I will skip all that. This important piece of work, I mentioned that women do better. And look at this. This is the key slide for any cancer work, that the FGF fibroblast growth factor 8 is an androgen-induced growth factor. And I thought that this could be the reason why men suffer badly, because the overexpression of FGFs or FGFRs has been observed in different cancers, including prostate. So I worked on that and then found out that in the animal model, in the nude mice, there was significant finding of androgen receptors and FGFR staining. Unfortunately, it was not in the epithelium, it was in the stroma. We did publish this. Altaf is a colleague of mine now. He was my research fellow at that time. And Sue Watson, who was the professor of cancer research, unfortunately, she's no longer with us. You all know that there are commercially produced cell lines. We produce our own cell lines so that, and named it SYY1, SYY, that's Syed Iftikhar, okay? And with those cell lines, we worked on the hypothesis and eventually, I just found this, that in the esophageal cancer, there is significant amount of ER beta receptors found. Compare that with androgen receptors, compare that with the in the tumor. The ER beta receptor is higher. Compare that with the ER alpha. Beta receptors have significantly high number, and tested this in the lab with flutamide, tamoxifen, estradiol, and etoposide. And one slide to just look at is that with different concentration of tamoxifen, there is an effect of blocking the cell progression. And this is what we are working on at the moment. I'm convinced that there is a lot of mileage in the ER receptor blocking agents in esophageal cancer, because flutamide, no effect, etoposide, no effect, estradiol actually causes progression. And this is the paper we published recently. And we are doing in vivo study on that. We are actually working on the cancer patients who have esophageal cancer. We are treating them with tamoxifen. We can do it ethically. We can't do it on everyone. So we are only doing on those patients who have got advanced disease. And it has been decided that all available therapies, including the immunotherapy, is not going to work. So we are trying tamoxifen on them and see what is the outcome. I won't go into the detail of that trial, but you will see in years to come what that shows. Thank you. Thank you very much.
Thank you, Iftikhar. Again, another very enlightening talk about upper GI, especially esophageal cancers. Again, from a primary care perspective, again, I can't see any questions in the chat at the moment. So if people would like to add any while I'm speaking to Iftikhar, what
I will just
say?
say one thing. I'll just say one thing, Shahid, before you ask me anything, is that Khurum had already shown you the slide of presentation symptoms. In primary care, anybody who presents with iron deficiency anemia or dysphagia, they should be sent to gastroenterologist or the surgeons for endoscopy. It's mandatory. In primary care, there's no room for treatment with PPIs of these patients without really knowing exactly what's happening.
Okay. You did, in the middle of your presentation, you talked about PPIs and the effect of bile reflux it has. So are you saying basically PPIs over time can cause upper GI cancers, or is that still jury still out?
Yeah. It's a very bold statement if I say so. What I propose is that these people should have, if they are symptomatic and they have long-standing Barrett's, they should have anti-reflux surgery. Now, Tom Hennessy from Dublin, he wrote a paper of anti-reflux work, his lifetime work of 260 cases or so. But those days it was done by open method, but nonetheless, very good surgeon and very well done. And he did not show any change in the outcome of Barrett's esophagus in post-frontal plication cases. So that's an issue. But I do believe that if you take away the injury, the agent which actually hammers the Barrett's all the time, all the reflux rate can be stopped coming up. It should have long-term outcome effect. Yes.
Okay. Thanks for that. Let's see if we have any questions. Someone's asking if you put an esophageal stent in, how long will it last?
So there are various esophageal stents. For one good thing is that it's now all endoscopic. The absorbable stents, they are placed in those subjects where we think that the condition could be benign and we just want to give them relief for a while. Those who are the permanent stents, the covered stent and uncovered stents. The covered stents are better, but they slip far more down into the stomach once the treatment becomes effective. If you have a stent in any subject and if you want to resect, then it's difficult. Please do not put a stent in those subjects who will go for surgery. Moreover, if you have a stent in those patients where treatment has just commenced, then some of them will have the problem, as I mentioned, the stent may slip downwards into the stomach. So when you are operating on them later on, make sure that you remove the stent. I've seen cases where surgeons have tried to do esophagectomy and a stent is still in there. So you have to be very careful.
Okay.
But absorbable, non-absorbable is the covered, non-covered metal stents or PDS stents, they are all available.
Okay.
And they are far better than the times when Celestin, Musibabin, tubes, all those were put at thoracotomy. They were intraoperative stents, and those patients never ever lived thereafter. For those who work with these patients, they will realize that pain is quite a prominent symptom with the stent. The esophageal dilatation due to the stent can give a lot of pain, and sometimes perforation as well.
May I ask a question, Dr. Gill?
Yeah, please carry on. Yeah.
Excellent presentation, Mr. Iftikhar, as always. One thing, I mean, you mentioned covered stent. As cardiologists, if we ask for one, that means coronary artery is perforated. So we don't use that much. Question is more of a generic one. In your experience, and maybe at your trust, has there been any difference pre and post COVID in terms of referrals to your service, 2-week wait, and because there's been recent news articles coming out. So how do you see that going forward? Has there been any impact in your practice or nationally?
Saqib, I hope you can hear me. I couldn't get any of what you said. I really couldn't. It must have been a very good question, and I would love to answer that, but I couldn't get it.
I'll repeat it. Can you?
Yes, I will get it. Just let me put my headphone on.
Actually, Saqib, there's a bit of an echo coming from your end. Yeah.
Yep. Okay. Far away.
Can you hear me now?
Yes, very well.
Brief question then, just to summarize. Have you noticed in your practice any difference pre and post COVID in terms of these 2-week pathways for upper GI symptoms being referred for cancer investigation? What's your experience? Because there's been some recent news articles on it.
Yes, there is. First of all, as I said to Shahid the other day, I was talking to him about it. I said, we were very fortunate that delay in our unit was not more than 6 weeks for any case. But there was reduction in the number of 2-week wait. And especially there was reduction in the number seeking endoscopy, because we had actually, units had stopped doing endoscopy for 4 or 5 weeks. And once we sorted out the issue and how we will operate, how we will gastroscope, what sort of PPI we will, PPF we'll use, what protection we will use, then it all came back, and we did not let any that I know of. I'm the lead MD of the MDT, so I know the data. We did not let anybody suffer. What we did do is to, if we couldn't operate, we gave them prolonged courses of chemotherapy. If suppose they were going to have neoadjuvant treatment for four courses of FLOT, we gave them 5th course. That will take them 3 or 4 weeks further on. So that's how that will impact. I don't know. The data will tell you that it may be very good. That if you use 4 cycles and more, that may give you better outcome in the long term. Or it may tell you that no, we didn't service care for these people very well. Those were the difficulties, but we, by and large, we really did not let many people suffer.
Great. Thanks, Iftikhar. Thank you so much for a very informative talk. We'll move on to our next speaker. And I'm glad to say with our next speaker, there can be no male or female bias. It is all male. So Tariq Sami is a consultant urologist at City Hospital. I've been there for some years. And again, Tariq's going to talk about common management of prostate cancer across secondary and primary care. Thank you, Tariq. Please start your presentation. Thanks.
Thank you, Shahid bhai, for the very kind introduction. Assalamu alaikum, everybody. Thank you for giving me this opportunity. Really a great pleasure. Excellent talk so far by both Khurum and Iftikhar bhai, as always. So I'm going to share my screen and discuss a little bit about the prostate cancer as we know it now. So before I go into the talk, I don't have any affiliations to disclose in the context of this particular presentation. We are going to have an overview of discussion first. It will start with PSA and its counseling and checking. There has been some refinement on PSA. We'll move on to referral on 2B28 pathway, and then new plans for straight to testing and MRI in primary care. We'll talk about prostatic biopsies, staging, and PSMA PET scan, which is comparatively new. Then we will talk about the options, oligometastatic prostate cancer, which earlier Khurum was talking about, oligometastatic disease. Then metastatic prostate cancer and some terms such as castrate-resistant and hormone-refractory prostate cancer. Hormonal manipulation strategies, we will touch a little onto chemotherapy, immunotherapy, radiotherapy, but we will just mainly discuss the side effects of hormonal manipulation, because that is what we come across, particularly in the primary care. We will also have a little case study, and then move on to question and answer after discussing something about diet, because in the primary practice, I think every patient asks, can I do something about my diet to reduce the chances of this cancer, or how can I avoid it? So as you know, that prostate cancer is the most common cancer in men now. And why it is important to find it and treat it early, because management in early stage can result in a survival rate of almost 100%. This is amazing. However, if it is diagnosed late, then the 5-year survival drops to about 30%. To facilitate the diagnosis, we have got a test which was introduced in late 80s and then took up in 1990s, and has resulted in a huge shift of mortality, particularly in America. And more people can now survive thanks to this test. However, this test, I call it persistent source of anxiety, both for the physician and for the patient. What it is an enzyme which is produced by the prostate gland. It is very high in value in semen, where it helps to liquefy vaginal secretions, and it plays an important role in fertility. In blood, it only comes in when there is a little breach in the basement membrane, and the values can be high in BPH, urinary tract infections, and prostate cancer. So it is not entirely for prostate cancer, and the commonest cause of raised PSA is actually benign prostatic hyperplasia. So the important thing about PSA checking is that the patient should be fully informed about the advantages and disadvantages of PSA. The biggest advantage is early detection and early treatment of prostate cancer if it is found, but the limitations are that it can be false negative, false positive, and then patients will be going forward either to have biopsy, not to have biopsy. All these questions come into their mind. Okay, it can also lead to unnecessary investigation and unnecessary treatment, particularly if we find a very small amount of cancer, then and patients, because of their anxiety, go for major radical surgery. So this has been had been a problem in the past, and now there are new avenues which have opened because of our better knowledge of the disease process. When to check this PSA, the target population is around 50 years. This is both the guideline from NICE and European Association of Urology. However, if somebody has a family history or is of Afro-Caribbean origin, they can have this test at 45 years of age. It can also be done in anybody who has a life expectancy of 10 to 15 years and wishes to have this test. When I talk about family history, it is the first degree relative who have been diagnosed before the age of 60 years, those who have Lynch syndrome. And particularly now, there is interest in those men whose mother or sister had breast cancer and that was BRCA1 or 2 positive. So our family history portfolio is slightly increasing. We have to have a discussion about the PSA test before it is done with the patient, and there are many resources one can get to from the primary care. These are all available online. The little meter which has been shown here is from the SWAP online aid, and patients can put in their family history, their PSA, their age, etc., and then can get a fair idea about their risk of prostate cancer, and then subsequently have a PSA test if they so wish. Not only with the man who has a family history or who is of a certain age needs a PSA test. One must also consider a PSA test in those who have lower urinary symptoms, erectile dysfunction, visible hematuria, and those symptoms which cannot be normally explained and could be generalized symptom due to cancer, such as backache, bone pain, weight loss, as we have alluded to earlier by the two speakers. We have moved on from the screening of population because we now know that it doesn't really work in the sense that if you screen population, then for one death per 1,000 people prevention, you would have, sorry, for reducing one death, you would have to treat 1,000 patients. Generally, in the studies that were done in the United Kingdom, the number was actually 1,400. So in the computerized models, yes, it says that you can reduce 1% of deaths, like 1 in 100, but in the actual world, it is much higher. So I think people have gone off the idea of screening. It is not a policy any longer. One must be very careful, particularly in the primary care, as how to do PSA checking. And it is one of the problems which we face in the secondary care when patients who had presented to the GP surgery with urinary tract infection and lower urinary symptom as a result of that end up having a PSA. That's a dilemma which we have to deal with. It is, as we all know, it's a blood test. One must make sure that there is no sign of infection before doing this test by carrying out a simple urinalysis. It will solve a lot of problems. One must also ensure that patient did not have any ejaculation for 48 hours before testing, and particularly during sexual activity. Nowadays, we have got a lot of gay population that they don't have a prostatic massage. If they had a prostatic massage during sexual activity, one must wait for at least a week before doing this test. One must also ensure that they did not have vigorous exercise, such as cycling for 48 hours beforehand, because that can raise the PSA level. There is a debate about getting a gentle digital rectal examination, which urologists do all the time in our clinics. It doesn't seem to be affecting the amount of PSA that comes into circulation if it is done gently. But if you are in the primary care and you are really not used to doing a gentle DRE, better avoid it. So these are the sort of things which one must look at before simply sending somebody for PSA testing. Now, the PSA itself has been under a lot of strain because, as I said, it can be increased due to benign prostatic hyperplasia, due to infection. So it is not a very, very good test. And then people have tried to find out other tests. And Khurum is sitting here listening to this. He must come up maybe in future some other very fine liquid test for this. So people have started looking at PSA density, particularly in relation to those glands which are large. And a cutoff figure of 0.15 microgram per ml of PSA was thought to be safe if the PSA is less than that per ml of the prostatic volume, then the chances are that it is due to the large prostate rather than due to cancer. There has been quite an interest in PSA velocity and its doubling time. It is mainly used for surveillance purposes rather than in the primary care or even secondary care for looking at PSA and making decisions. We also went through a phase when we were doing free versus total PSA, but that has now been almost discarded except in a research context. We have got prostate health index, 4K test, and other PSA and tumor suppressor gene related biomarkers, but those have not been in the mainstream. So PSA, although not the best test available, remains the mainstay of our decision making. So once the patient has been fully counseled and decides that they want to have this test and the GP decides, let's go for it, and the results come in, that it is high. And high is basically on the basis of age-related PSA. One must also do a digital rectal examination and look at other symptoms, but age-related PSA and DRE findings are the reason for 2-week weight referral. Once you have the 2-week weight referral, what we do in secondary care, we carry out a detailed history examination, carry out blood urinalysis, and multi-parametric MRI. Multi-parametric MRI, as you know, had been there for many, many years in the background, but there was a trial in London, and after that, it was called Promise Trial, and it has now become a mainstream, and most of the centers carry out multi-parametric MRI before proceeding further. At the minute, 2-week weight pathway is on the basis of 31, 62 days criteria, but NHS England is trying to have a faster diagnosis standard of 28 days. In 28 days, you should be told whether you have or don't have a prostate cancer, and the first treatment may have been taken by then. As a result of that, there is a drive to carry out straight to test multi-parametric MRI, and people are thinking of giving this very important piece of investigative tool to GP surgeries. I will go into the more details about this. And then once you have the information from your MRI scan, prostatic biopsies, diagnosis, staging, and treatment will take place. So the question is whom to carry out multi-parametric MRI. The important thing is when they are seen in the primary or even in the secondary care, they should not have biopsies done in the past, particularly in the recent past, because that can affect the interpretation of signals. It is a very straight test. There are very few contraindications, and most of the people who are in this particular age group can have this test without any interference. Claustrophobia remains one of the main problems where patients cannot go through the little tunnel, and every now and then we have patients who simply say, sorry, we cannot have this test. Another problem, particularly in England and in some parts of the USA, is obesity. The tunnels are small, and on a few occasions, believe it, we have to send our patients to open MRIs in the zoo because they have got these MRIs for very large animals. Anyway, when we talk about MRI, the immediate question is, what does it show? So the interpretation of the data or signals is based on prostate imaging reporting and data system, or PIRADS. So if somebody is having a PIRADS 1 signal, then their likelihood of cancer is very, very low. On the other hand, if it is PIRADS 5, it is highly likely that they have prostate cancer. Why to do MRI in the first instance? So on the basis of PROMISE trial, they suggest that if people have PIRADS 1 or 2 lesion, then the chances of finding a significant cancer are very, very low. So they can be excluded from having a biopsy until and unless they are very twitched about it and they want to have it done. PIRADS 3 is equivocal. You can leave the decision making between the urologist and the patient. But if suppose PIRADS 1 lesion or no PIRADS 2 are seen, then in the primary care you can decide that, well, somebody should go for biopsy or not. Next step in the diagnosis is prostatic biopsies. Now, we have been used to transrectal ultrasound guided prostatic biopsies, but over the period of time, they have been a cause of significant infection. In fact, 1 in 10,000 patient can die because of the severe infection due to transrectal biopsy. So they are actually on their way out. What is coming in is transperineal biopsy, and most of the centers in the UK are converted to this way of biopsy. Our center is also looking at doing it, and hopefully before the end of this year, we will be there. There are other type of biopsies, such as fusion ultrasound MRI biopsies. They are done in selected centers for specific patients, and template biopsies, which are, again, selected cases where we are thinking that the tumor may be more anterior. These are not widely available, but in selected cases, the patients are then referred on. So once you have done the biopsy, what type of result we get? I'm sure most of you are familiar with the Gleason score, that it is from 1 to 10, and the lower the score, the differentiated is the cancer, and it is less likely to cause problems. But if the higher score is there, then it is going to be more aggressive kind. The new thing which has come out is grade grouping in the last few years. And why the grade grouping has come in? Because particularly when look at Gleason score 7, you have got 3 plus 4 is equal to 7, or 4 plus 3 is equal to 7. They are both 7, but when you have Gleason 4 cancer, there is it is a more of aggressive type. So therefore it has been changed into grade group 3. The rest basically remains the same, but it is easier to interpret that if it is grade group 3, you are talking about a more aggressive cancer. Prostate cancer, as you remember, is one of those where you can have it in a sort of very indolent fashion, or it can kill an individual within no time. So you have now gone through the MRI scan, you did the PSA, you got your MRI scan, you have the biopsy. Next stage is staging. So in the past we have, well, until now we are doing CT and bone scans. These are the standards wherever required. In some cases, we don't even have to have those. The information which we get on MRI is enough for decision making. But if the PSA is high or there is a high group grade, then we go ahead and carry out further staging. In some cases, we do not get the information which we need on the basis of CT and nuclear medicine scan. And nowadays, in those sort of cases, or if we are thinking of recurrent diseases, we have got PET scans. It's a PSMA PET scan shown here. PSMA is a transmembrane receptor, which about 80% of the prostate cancers show. And it is easy enough to get it done. However, the costs are high, not easily available. We have to request it specifically. Now, after all the staging, after all that counseling, you have come to the diagnosis and you are going to discuss outcomes in the MDT. So basically, one can have an organ-confined localized cancer, or they may have metastatic cancer, which may be again divided into large volume visceral and bone metastasis or oligometastatic, or you have a third situation where you have a palliative treatment depending on the patient. So if you have localized prostate cancer, what are the options? Our experience has shown that active surveillance can play a huge role in monitoring patients who have been diagnosed with prostate cancer. It's a quandary. On the one hand, we are saying that you diagnose somebody within 28 days because it's jungle fire, it's going to go out of proportion and will kill the patient. And on the other hand, we are suggesting surveillance. This is something which patients find sometimes difficult to comprehend, but when explained nicely that you are very young and your cancer is of a favorable variety and it's low volume with low PSA, we can keep it under surveillance, they do very well, rather than going for major surgery or radiotherapy with its effect, such as urinary incontinence or very significant erectile dysfunction. I mean, in a young man in their 50s or 60s, not really acceptable. So low volume, low Gleason score, T1, T2 cancers are the ideal ones for this site for active surveillance. But recently there has been an interest in intermediate risk prostate cancer as well, where the PSA is 10 to 20 or Gleason score 7 with clinical stage T1 or T2. They require a little bit more surveillance, but can be done. So what does active surveillance means? Basically, they need regular PSA checks at 4 to 6 months, annual digital rectal examination, repeat MRI scans, and repeat biopsies. There is another term which we use quite often, which is watchful waiting. It should not ever be confused with active surveillance. In watchful waiting, we are basically deferring treatment for men who cannot undergo curative treatment. Active surveillance is definitely for with an intent to have curative treatment at a later date. Beside active surveillance, we have got other options. That is for the patients who have got higher grade cancer or who just do not want to have this anxiety about having a cancer which may actually at some stage progress. So surgery can be offered to them. Surgery has been there for quite some time, or it can be done by open laparoscopic or robotic method. Lately, robotic prostatectomy has taken up around the United Kingdom, and I think there are about 81 robots working in different centers. It is really a game changer because there is very rapid recovery. The dissection is better. The side effects are lower, and patient can go home next day with a catheter, which then removed in about a week or 10 days, and they can be on the golf course next week. Similarly, radiotherapy can be given with the intent to cure, along with new adjuvant hormones. We have also other options such as brachytherapy, high-intensity focused ultrasound, and cryotherapy for younger patients and a small volume disease. Oligometastatic prostate cancer is something which we have now looked at. The consensus is that if you have 3 to 5 areas of metastasis, and particularly bony metastasis, these can be treated in a different way. Once it is diagnosed, it can be treated by hormonal treatment, as well as upfront chemotherapy, followed by radiotherapy to the primary, as well as to the metastatic side. Can have surgery in very selected cases, and SABR, which is stereotactic ablative radiotherapy to the bony metastases, which are in sites such as the skull or vertebra.
Tariq, I think we're running out of time. Yeah.
Okay.
I mean, can you just wrap up in the next minute or so?
Sure, I will.
And perhaps, you know, if anyone has any questions, sorry for interrupting.
No, not at all. That's fine. That, I think, was the crux of the thing from the point of view of primary care. Next is about metastatic prostate cancer. We know that it can be treated with hormonal manipulation, chemotherapy, and immunotherapy. My next slide would be more about the side effects of androgen deprivation treatment, which you see quite a lot in the primary care. Loss of libido, shrinkage of genitalia, breast tenderness, and particularly metabolic syndrome and cognitive impairment can be a cause of concern. I would not go into the case study because of the being slightly short of time, and then move on to
I mean,
diet and prostate cancer, which is a question which is asked by every patient in the primary care I have come across. So there are some adverse risk factors such as high animal fat, processed red meat, saturated fat and salt, high calcium intake in the diet, and sedentary lifestyle. Make sure that your patients eat a lot of fruit and vegetable. There are some chemoprevention available, such as 5-alpha reductase inhibitors, and healthy lifestyle.
Yeah, I would really like to thank you, Tariq, for quite a comprehensive walkthrough from beginning to end, and an excellent overview of what GPs can expect and what they should do. Just a quick question. In your early slide, you mentioned that before doing a PSA, we should consider lower urinary tract symptoms and erectile dysfunction. So how do we correlate PSA or prostate cancer to these symptoms, Tariq? Is it something specific or non-specific?
It is non-specific,
yes,
but it's a sort of screening by backdoor, you can say. So those patients who are coming with erectile dysfunction, they are usually in the same age, like 40 plus, and that's when you can carry out a PSA test, and sometimes you find a prostate cancer. It is also in the same lines, like when you look at erectile dysfunction recommended tests, lipid profile, for example, is one of them. Blood sugar is one of them. So similarly, you can have PSA done at the same time.
Okay. Thanks very much. I think we'll have to move on. If people have got specific questions for Tariq, we'll try to address them at the end, which is just about 25 minutes away. Try to finish on time. So I'll move on to our final speaker for the evening. And Really happy to welcome Sadaf Jafferbouy, who is a consultant oncoplastic breast surgeon in Stafford at the University Hospital in the North Midlands. Again, I think such a common area of referral for GPs with the 2-week wait. We often get women coming in with breast pain, which might have gone on for a month or so. We might get people with skin changes around the breast. So, Sadaf, thank you for joining us this evening, and the floor is yours. Please carry on.
Thank you, Dr. Gill. It's an absolute pleasure to be here and give a talk on this forum. I'll just make sure I can share my screen. I know there was some hitch earlier, but if not, then I'll ask Saqib to share my slides. Okay, Saqib, would you mind sharing my slides, please?
Just give me a moment. So while I'm sharing, Mazaba, you're the host because I won't be able to see anybody else. Can you
While you're waiting for that, again, any questions people may have, colleagues may have, please put them in the chat. I know we've covered a lot this evening, and it's been quite a lot to understand. But I think what's been fascinating is the huge developments taking place in the genetic sort of field. And I think a lot of cancer diagnosis and treatment will in the future probably be around genetic testing and smart drugs tailored for genetic markers and things. So again, any questions, please put them in the chat.
Can you all see the screen? Just let me know.
Yeah, I think we're okay.
Okay.
Please carry on. Thank you.
Okay. So thank you very much. Apologies for this. As always, technology lets us down sometimes. Can I have the next slide, please? So before I start my talk, I've got no conflicts of interest. I've got no disclosures to declare. So when I was given this talk about what GPs can manage in the primary care and what needs referral as a 2-week wait, I thought I'll just look up and see what is happening. And I'm sure you've seen lots of things in the newspapers, which certainly becomes the headlines. And it's not a surprise that many hospitals are failing to meet the 2-week wait targets, be it north, be it south. Certainly, I know there have been few big hospitals that have been in the papers, and mainly because we are just not meeting the 2-week wait referral targets. Can I have the next slide, please? So what has actually happened in the last few years? This is the slide from Public Health England. And as you can see on the left, the number of referrals have significantly gone up in the last decade or so. So back in 2009 and 10, we were talking about roughly about 400 referrals per 100,000 people in the community. And now this has risen up to almost 750, approaching almost 800 in the current era. But interestingly, the conversion rate has not changed. So previously, our referral to cancer detection rate was hovering around 10% going back 10 years ago. But this has significantly come down, and we see a conversion rate of almost 5.5%. And this is the data which is from last year. And as the numbers have gone up with terms of referrals, I wouldn't be surprised if this graph further comes down. Can I have the next slide, please? Keep on clicking, please. So we know that this is the slide from Clinical Knowledge Summary Guidelines, and this is no surprise to you that the guidelines do suggest that anyone who's got a breast lump above the age of 30, they should be referred to the breast clinic as a 2-week wait, or anyone who's got nipple changes like retraction or discharge, it is a no-brainer that they need to be seen as a 2-week wait. The guidelines do suggest that one should consider urgent referral for anyone who's got skin changes that could be suggestive of breast cancer, or someone who's got an unexplained lump in the axilla. The non-urgent ones are the ones where someone is under the age of 30 and they've got an unexplained breast lump without pain. But there is a lot more in terms of breast problems, which does not fit into the criteria for urgent referrals or even non-urgent referrals. And what do we do about them? And this is the thing that primary care physicians do come across on a daily basis. I can just sense this because the number of referrals that come through, I'm sure in primary care, there's a lot more patients being seen compared to what we get in a 2-week wait. Next slide, please. So I'm going to talk about isolated breast pain, nipple discharge, what to do when someone has got a rash on the breast, and gynecomastia. So as you can see, none of them are breast cancer related topics, because I'm sure if you see someone who's got breast pain and you're worried about that they've got breast cancer with all the signs and symptoms, you will send them as a 2-week wait. Next slide, please. You need to click a few times. So breast pain, it is one of the commonest symptoms for which ladies attend the breast 2-week wait clinic. We know it is very common. It affects 70 to 80% of women in their lifetime. It can be physiological. It could be cyclical breast pain. It can be associated with pregnancy or lactation, but it could be non-cyclical. And there's a range of reasons why ladies can have non-cyclical breast pain, including infection, inflammation. Now, some ladies do think if they've got a mass and if they've got breast pain, maybe they've got an underlying mass, but we know that the malignancies, they generally do not cause breast pain. Next slide, please. One thing that is very important to differentiate if someone presents with what they think is a breast pain is it actually breast pain or is it chest wall pain? Sometimes it can be tricky to differentiate between the two. But commonly, sort of chest wall pain, it can be unilateral, it could be focal. Ladies may often say that it is exacerbated by certain movements. On examination, you may find focal tenderness when you apply pressure. And remember, there are causes like costochondritis, teeth syndrome. Often muscle strain can give them pain, or if they've had a soft tissue injury. Next slide, please. So there is a lot of things that can be done in the primary care. And I spend quite a lot of time discussing with these ladies about simple things. These are not medications, but simple lifestyle changes, i.e. changing their diet, reducing their caffeine intake, because there is some evidence that caffeine can make breast sensitive. It is very important to make sure that these ladies wear a well-fitted bra. It is unbelievable the number of patients that come through the doors and they are not wearing the right supportive bra. Either this is too loose, too tight. It's as simple as that, getting a bra fitting check, just really to make sure this is not the cause for their breast pain. There is lots of studies done to say relaxation and complementary therapies help with breast pain, because breast pain can be related to stress levels. And I'm sure primary care physicians all know that it could be related to the use of hormones like contraceptive pills or HRT. But usually this pain should settle down within a few weeks of starting treatment. And if it doesn't, then it's one thing to consider. Some ladies use evening primrose oil, and there is some evidence that this is helpful. What is the right dose? It's usually a gram TDS. Is it going to be effective? You have to be very honest to the ladies and tell them that it may not be, because there is a group of patients who've used them, sworn by it, and said this is miraculous drug. Others have used it and found no difference. You can try pain relief like topical non-steroidals, or even consider using ibuprofen. Hormones, there is evidence that use of low-dose tamoxifen for a temporary period of time or danazol may be effective. But generally, you would not want to jump onto these medications till you've tried something simpler. Breast pain chart, sometimes it's not available in primary care, but it is a chart on which the patients can jot down the intensity of pain. This chart has to be filled in for at least 3 months, really to differentiate whether it's cyclical or non-cyclical breast pain. This chart is available on Breast Cancer Now website. Next slide, please. So the big question comes is when they come to 2-week wait clinic, do they all require imaging? And the answer to it is no. If a lady comes who's under the age of 40 and her clinical examination is normal, she will be discharged with the same advice as I've just talked about. She does not require any imaging. And sometimes patients do get really upset when they're informed that, yes, your clinical examination is fine, you don't need any imaging, because they come in, I think, with that thinking that they will be scanned somehow or the other. Likewise, if someone is in the screening age group and they've had a mammogram less than 12 months ago, if the clinical examination is normal, we don't repeat a mammogram. However, if someone has got an abnormal clinical examination, they have an ultrasound scan irrespective of their age. But if they are above the age of 40, they will have a mammogram as well. And in ladies who are above the age of 40, but they're not in the screening age group, with a normal clinical examination, we will still do a mammogram. So next slide, please. So why do we do a mammogram? I hope the calcifications are projecting up very well. This is the area sort of behind the nipple. And this is the reason we do mammograms, because what we are trying to look for is any microcalcification within the breast. Because as you all may know, that microcalcifications can be a sign of DCIS, and that is what we are looking for. But is DCIS a cause of pain? Not really. Next slide, please. So these are some studies which are done. Some of them are from the UK, a couple of them are from Europe and from other countries. And there is one thing that is quite consistent in all the outcomes, is to say that these are patients who have presented with breast pain, be it isolated, be it focal, be it non-focal. There is no real increase of the incidence of breast cancer in these women. There have been DCIS or breast cancer detected on the contralateral side, which is purely incidental, but we know screening does that too. Next slide, please. So when to refer, and these are some of the 2-week wait referrals from different trusts that I came across. But one thing is quite consistent, that patients who have got persistent breast pain, they should be referred to breast clinic and on a non-urgent or a routine basis. So none of them sort of would follow the criteria to be sent as an urgent 2-week wait referral. But persistent is the term that is used consistently. And that means you would have tried everything in the primary care before they are sent to the 2-week wait clinic. Thank you. Next slide. So now moving on to nipple discharge. And again, these are the commonest things that I'm sure you see in primary care. We know that in our practice, nipple discharge accounts for almost 5% of the breast referrals. It's a poor indicator of malignancy. It could be physiological or pathological. Next slide, please. Keep tapping, thank you. So it could be multiductal, it could be uniductal, and that's the kind of things you will find out from your examination and from your history. But remember, physiological discharge is usually whitish in color. If it is greenish in color, this could be as a cause from ductictasia or periductal mastitis. Galactoria or milky discharge, there is a range of drugs that can cause it, could be from prolactinoma or hypothyroidism. At the bottom, I've written uniductal discharge, and these are the kind of discharges that concerns us, because it could be an indicator of an underlying papilloma, which could be related with atypia, hence DCIS, and a very small incidence of cancer. Next slide, please. So the ones that need to be seen as a 2-week wait are the nipple discharges, which are spontaneous, they are unilateral, they are uniductal, i.e. coming from only one duct of the breast, of the nipple. Either it could be clear or blood-stained. So the nipple discharge that comes on manipulation of the nipple is not something that we would be concerned about. Hence, they do not fulfill the criteria for a 2-week wait referral. Next slide, please. So just to give you an idea, what happens when these ladies come in the secondary care or in 2-week wait clinic? As you would do, we would take a history, we would do a clinical examination. We would do a mammogram if they are above the age of 40. Then we do an ultrasound scan of the retroareolar region, which is the area behind the areola, just because mammograms can sometimes not pick up if there is any abnormality within the ductal tissue that is very close to the areola or to the nipple. In some units, ductoscopy or MRI is being done, but in most of the units, generally they would stop on ultrasound and mammograms. So even if the mammograms and the ultrasound scan are all normal, we would offer them a total duct excision. The mammograms that you can see on the screen, I'm not sure how many of you can appreciate, there is a little marker clip just behind the nipple. And what essentially this lady had was an ultrasound scan. You can't see any abnormality on the mammograms, but on the ultrasound scan, she had a 4 millimeter papilloma, which has been biopsied. And at the same time when she had the biopsy, she had a marker clip put in, and now she's coming for a total duct excision in due course. Next slide, please. So what about the rash on the nipple? Now that is one of the reasons we get lots of ladies coming through. When you see someone who's got a rash on the nipple, you got to question yourself, is it involving the nipple? Because what you're worried about is it Paget's disease? If there is a rash which is involving the nipple, you're quite right, you would be worried if this is Paget's disease. Is this associated with any lump or any other skin changes? Are you dealing with an inflammatory cancer? Have they had previous history of radiotherapy? And I'll talk to you sort of what happens after radiotherapy. There is a risk of developing angiosarcoma. The risk is very small, but it could be radiotherapy-induced angiosarcoma, which sometimes can get missed and gets picked up at a later stage. Sometimes detecting a local recurrence may be difficult if they've got extensive changes from the radiotherapy, and I'll show you some photographs of that. So next slide, please. So this is one of the ladies I had seen in a 2-week wait clinic a few weeks ago. She was sent to me to say she's got a rash on the breast, please examine, but actually it was just not a simple rash. She had an underlying lump. You can see how the skin is getting desquamated and deepithelialized. This was an inflammatory cancer. It's not a simple skin rash that you would just leave it in the community to be dealt with. Next slide, please. And again, this is a lady who was seen last year, right at the peak of the pandemic. As you can see, she's had a previous mastectomy, quite extensive radiotherapy changes. She didn't want to come into the hospital, and her GP kindly took the photograph and sent it to us. And we said, actually, we can't really tell much about just looking at the photographs. And I got her back, and just on the superior medial aspect of all these radiotherapy changes, there was a bit of a thickened area, which I did a punch biopsy on, and turned out to be a cancer. So if you see something like that, don't leave them in the community. They need to come back and see someone in the breast clinic. Next slide, please. I'm sorry, sort of this, I tried to magnify this picture just really so that you could have a good idea. This is a rash that was treated in the community with topical steroids. I think this again went on for 18 months or so. Different steroids got better, didn't completely go away. Because it was not responding to steroids, we did a punch biopsy and it turned out to be a superficial BCC. Now, there's a bit of an argument if you've got some skin rash like this, which is away from the nipple. This is not Paget's, but should they be seen in the breast clinic or should they be seen in a skin clinic? And it varies among sort of between trust to trust, and it depends where you are and what the nearby hospital would accept. We tend to see these ladies in breast clinic and do a punch biopsy, and if need be, refer them to dermatology. Next slide, please. So you would refer them to breast clinic. If someone has got a rash and clinical examination is otherwise normal, you give them a trial of 0.1% mometasone or 1% hydrocortisone. They need to be seen as a 2-week wait if they fail to respond to steroids. So you give them 2 weeks worth of treatment, reassess them. And if they are still not quite resolved, then they need to come back. Or there's a rash and you find the clinical examination has got more to add on to it, they need to be seen back. Next slide, please. So what about gynecomastia? That's another common reasons why men get referred to breast clinic. Now we know the incidence of breast cancer in men is about 1% or even less than that, but yes, they can have breast cancer. What is gynecomastia? It's an enlargement of male breast tissue due to hyperplasia of the glandular tissue, which I'm sure all of us know. It's the imbalance between the androgen and the estrogens. It could be physiological, it could be drug-induced, it could be pathological. Next slide, please. So which ones do you investigate in primary care? And I'm sure you all know this, that the ones who've got eccentric hard masses, there's rapid enlargement of gynecomastia. It's a recent onset in a lean man, more than 20 years old. If it is persistent, painful gynecomastia or persistent for more than 18 months, then you would investigate them in primary care. Next slide, please. So when do you refer them to breast clinic? Of course, if you've got any clinical suspicion of this being a cancer, they need to be referred as a 2-week wait. If someone has got a unilateral lump, although you think this may be a gynecomastia, but you can't really find a physiological or a drug-induced cause to account for this, they need to be seen in a 2-week wait clinic, or they've got increased risk based on the family history. For instance, uncle had breast cancer or grandfather had breast cancer, or some genetic conditions like Klinefelter syndrome. If they've got persistent painful gynecomastia that lasts for more than 6 months, and you've done all the blood tests, that includes the hormone profiles like FSH, LH, testosterone, HCG, renal function test, liver function test, you really cannot put your foot down to anything and you say, actually, I can't find a cause for this. It's more than 6 months. They need to be seen in the breast clinic. Next slide, please. So which are the ones that we do not investigate? So pubertal gynecomastia is something that we don't proceed with even doing any more tests. Elderly men with senile gynecomastia, where there's an obvious drug-related cause, or we think this is a fatty pseudo-gynecomastia, where it looks like gynecomastia, but you cannot feel the firm rubbery feeling behind the nipple. This is all fatty tissue, and that's what pseudogynecomastia is. Next slide, please. So in summary, isolated breast pain, refer to breast clinic only if they've got persistent symptoms. Nipple discharge only, it's a spontaneous, uniductal and unilateral, which needs to be referred as a 2-week wait. Rash, of course, if it fails to respond to steroids, and gynecomastia if it's persistent and there's no obvious physiological or drug-related cause. I'll end my talk here. So thank you very much for your attention.
Well, thank you, Sadaf Jafferbouy. Excellent talk. And again, you really touched on the common symptoms which GPs struggle with, as you said, discharge and pain. I've got a question from one of our colleagues on the webinar. Have you heard of star flower oil? I haven't. The question is whether star flower oil is better than evening primrose.
It's certainly something that we don't advise, we don't prescribe. It's not given any of the information leaflets.
Mm-hmm. Have you any evidence that bromocriptine works? Have you?
In terms of breast pain or galactoria?
Yeah, breast pain.
Again, before going on to bromocriptine, I think that the common practice is to try other drugs, such as danazol or tamoxifen, but we wouldn't go for bromocriptine generally in breast clinic.
Yeah, but as a GP, you see, I'd probably stick to something simple, you see.
Absolutely. We know that most of the time, all these ladies need is reassurance. They try simple painkillers and the pain settles down, give it a few weeks, couple of months, and it goes down.
Hmm. Excellent, really, really excellent talk. And I think at the risk of upsetting my previous colleagues, I think we kept the best to the last. But we have a few minutes for questions. If anyone would like to ask any questions from our previous speakers, except Dr. Khurum Khan, who's had to leave, please feel free and put them in the chat now. And we have a couple of minutes before we finish our webinar session. So I've got a question here from Mr. Mahbub Mirza. Do you think community breast pain clinics may be a way forward in reducing referrals, which he thinks is almost 20% of the referrals he gets? The second part of the question, there are a significant number of urgent referral lumps between 25 to 30-year-olds. And how common is breast cancer in patients below 25? That's two parts. One is about the community breast clinics, whether they'd stop you guys getting, really busy, and how common is breast cancer in patients below 25 years of age, please?
Okay, so there is an increasing drive of managing breast pain ladies, I wouldn't say patients, in the community. And there are some sort of tools coming out to say how these patients can be managed. There is specifically the criteria or the risk assessment tool would be to say, what are the risk factors? Because that is one of the commonest concerns these ladies have. If they've got enough risk factors, they can be referred to secondary care. But if they do not have enough risk factors warranting imaging, then they can absolutely be managed in the primary care. So this is probably going to be the way forward. It's still in discussion. It's not quite materialized yet. I know sort of towards in Nottinghamshire or Derbyshire, there is a proposal going on about this. The next question is, how common is breast cancer in 25-year-old or someone of younger age? Certainly not as common as you would see in ladies above the age of 40, as a result of which we do sometimes segregate clinics for ladies who are above the age of 40 and under the age of 40 or 35 in some hospitals. It is not common, but the worry always is when younger women get breast cancer, it tends to be the most aggressive kind of them. So it is not common. I wouldn't say uncommon, but interestingly, for some reason in the last year, since all this COVID has started, we are seeing a lot more younger women coming through the doors with more aggressive cancers. And younger, I mean to say 30-year-old, where you would just think this is nothing sinister.
Thank you for that. Final question. I've got someone again talking about hormones are always a worry with breast cancers. So how much do oral contraceptives have a risk with breast cancer?
So it's a contributory factor. And again, it depends what kind of oral contraceptive pills they've used and how long they've used it for. It's the same thing like with HRT. We know that extended use of HRT increases the risk of breast cancer. So if you remember sort of some time ago, there was lots of scare in the newspaper and there were lots of articles that came through, but equally, I think it was the British Menopausal Society who had put through and said, actually, it's not as bad. But of course, we know if someone is been on HRT for more than 10 years, the risk of developing breast cancer is higher, or if they're using HRT beyond the postmenopausal stage, then it's fine. But most of the ladies using oral contraceptive pills, as long as they're not taking for a long period of time, the risk is dependent on the duration or the exposure and what kind of contraceptive pills they're using.
Great. I think we have to end it there. It's been a wonderful evening, very informative. We've really had a run through of very hot topic areas within the cancer theme we've had this evening. I feel more knowledgeable after a couple of hours and more confident in the decisions I'll be making. So huge thanks to all our speakers, excellent presentations and talks to all of you. Again, thanks to our sponsors. And I'd like to thank especially Saqib Ghani, our president, for his support in getting this organized. And even today, he's been so busy organizing the IT and the links and everything. So Saqib, it could not have happened without you. Okay.
Thank you,
So
Mr. Gill. But just one thing, I was
thank you.
going to the chat. There's one question which we missed. I think it
Yeah.
was from Tariq Sami to Syed Iftikhar. I think it only came up when
Please, yes. Okay
Tariq Sami
then.
started. Tariq bhai, you can unmute and ask yourself, was it about robotics and role of robots in upper GI surgery? Something like that?
Yes, basically I was asking Ifti Bhai what is his view on robotic surgery for esophageal cancer, and particularly now that it is, you know, if he thinks that it can be prevented by treating reflux. There are many people who have got reflux.
Tariq, this is a very good question. Yes, robotics is here to stay. Robotic surgery is being done in various centers and it is very effective. What I didn't touch upon is the management of the early esophageal cancers, like using radio frequency ablation of Barrett's, using the submucosal excision of early in situ carcinomas. Those things are now being done and very effective. So there are more and more cancers in elderly people who can't go through major surgery. It's being done by endoscopic methods. And robotics is new. It's no different to the way we operate with the hybrid method of laparoscopy, and the outcomes are similar. So the changes are coming, and these new changes will improve things, and they are here to stay. Yeah.
Thank you. Ifti Bhai.
I think we close it at that. So thank you so much, all the speakers. Absolutely fantastic talks. Thank you to all the participants. It's also not possible.
Saqib, before you close, can I just say one thing? I think it was Mariam who asked, can the stent get blocked? Yes, the stents do get blocked by overgrowth from above or below, or migration. We have to use fizzy drinks all the time to keep them clean and unblocked. If it is due to overgrowth, then we can put another stent within that stent. So yes, they do get blocked. Okay.
Okay, so yeah, thanks to all the speakers. Thanks to all the participants. I think a webinar cannot be done without participants, and it's very difficult to speak to pictures. But therefore, thank you for the interaction in the chat box. It really makes it a little bit more lively. But there's nothing you can't compare with real life. Anyway, on that note, we end this session. The meeting has been recorded. It will be saved and uploaded on YouTube later. Any feedback, you can email us. We have received your email addresses in the chat box. If you don't hear from us in a week or two with your certificate, by all means, all participants, remind us. Saqib Irfan has said 2 weeks, because next week we're quite busy. So give us 2 weeks, please, to send your certificates. And if there's any delay, please don't hesitate to remind us. On that note, all participants are requested to exit the meeting, and I'll stop the recording here.